everyone. I would like to introduce Sashi. Thank you.
Thank you, and thank you for that great stretch, Nancy. Good afternoon, everyone. My name is Sashi. I'm the Scientific Operations Manager of the Mira Dixon Hall Center. Before we get into our presentation for today, I'm just going to go through a bit of housekeeping. So bathrooms are located down the hall this way and to the left. You can also exit through the back door and go to the right. And we have signs up labeling the bathrooms. Healthy snacks are available. I hope everyone's had a chance to grab some food, but we have the food just out this door. We will have more snacks at the end of the presentation as well in the garden room. We encourage you to participate actively in the presentation today. Those of you who have been to these events before know we do a nice long question and answer period after the presentation. We have given everybody a cue card and a pen. So if you feel more comfortable writing down a question so that it can be anonymous, you're welcome to do that. And Nadia and I will be circulating to collect written questions. We will also have mic runners. Tajwar and Selena will be walking around with the mic. So if you feel comfortable asking a question that way at the end, you're welcome to do that as well. Please make sure you're not including too much personal information in your questions in terms of your personal health information. Any other housekeeping? I think that's it. So to get our Snacks and Science event started, I will just do a land acknowledgement. I want to begin by acknowledging that we're gathered on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. Toronto is covered by Treaty 13 and the Williams Treaties. These treaties are important in understanding the issues surrounding Indigenous land rights in Canada and the importance of reconciliation efforts today. This acknowledgement also holds personal meaning for me. My great-grandmother was born on the Oka Reserve in 1899, and much of our family history is lost, partially through gaps in documentation, but mostly because of the pressures and the discrimination that my great-grandmother faced. I want to honor both the nations who have cared for this place long before my family arrived, as well as the stories in my own family that were never allowed to be told. And I think Nadia is up. Oh, there you are.
Thank you so much for that, Sashi. And hello, everyone. Welcome again. My name is Nadia, and I am with... Just need to make this a bit higher. Okay. I am with the Mira Dixon Hall Center. As you know, it's a really great partnership between Dixon Hall and McMaster University. How many people here have come to Snacks and Science for the very first time? Okay. How many people have come to Snacks and Science 2 times? Today, another one. How about 3 times? You've been to 3 Snacks and Science, or from the very beginning? Okay, so this is amazing. This is amazing. Our fan base is growing. And it's really nice for us to see that you're benefiting so much from the work that researchers are doing at McMaster University. We make sure to use topics that we have heard the community wants to learn about, that are of relevance to the Downtown East community, which of course you can tell today's topic, anxiety and depression, is important, to be honest, to the majority of people have experienced this in some way, shape, or form. Basically, the Mira Dixon Hall Center, what we do is we bring together Dixon Hall's strong community connections, how well we work in the community, frontline programming, building those connections with McMaster's expertise on their research on aging, in terms of the technical tools they know, in terms of research. These partnerships are more common in European countries. It's not as common in the North American landscape. So it's really exciting, again, that we're able to offer this in our very community here in Toronto. There are many different ways to stay involved with the Mira Dixon Hall Center. One is through the Stay in Touch form. I know a lot of you have filled this out because, again, there's a lot of familiar faces. But if you are new and you would like to join our mailing list, there is a form at the front desk where registration is. You can be updated on some of our future projects in terms of research findings and, of course, future events. Another way is that we have a really amazing community advisory group. We have 11 very active members in that group. They're very familiar with the Downtown East. Some of them are Dixon Hall members. And so, what we do is we meet on a monthly basis, and that really is the way that the Mira Dixon Hall Center continues its promise to be centered in community voice, community needs. These are 11 people that are, of course, experts on aging, as well as this area. And so I think the majority of them are in the audience today. If you don't mind raising your hands, and can we give a round of applause to these amazing volunteers? They really truly enhance our work and make sure that people are happy in the community and it makes sense in terms of what we're doing. Another way to stay in touch is the event feedback form. So, in the packages you have on your chairs, at the back is an evaluation form. It's really just for us to understand who are the people that we're serving through the Snacks and Science. What are your thoughts on these events? How can we make them better? If you do fill out the survey, you can hand it over to Thujwar, who is the research assistant with us, or myself, or anyone else in our team. And we will submit your name in a draw, and we will pull a name out, and you could receive a $30 gift card. So last Snacks and Science, Femi Prudente was the winner of the gift card, which is amazing. A lot of us know Femi. She's an excellent dancer if you don't know her. And so, yeah, please fill out that feedback form at the end of the event. And that's it for now for me. I will invite on the stage Marla Beauchamp, who is the director of the Mira Dixon Hall Center, to introduce our amazing speaker, who many of you might know from last year. So, Marla, thank you.
Thanks, Nadia. Welcome, everyone. It's so great to see so many familiar faces and new ones every time. So it's really my pleasure today to get to introduce Dr. Anthony Levinson. He is here back on popular demand. He was with us about a year ago. He's a psychiatrist and a professor from McMaster. His research is focused on dementia and neuropsychiatry, and he's an expert in medical education. So we're really, really lucky to have him here today. And we're going to talk today about a topic that affects many of us, especially in this time of year when we get into kind of more dreary season. So Anthony's going to talk to us about anxiety and depression today. And I just wanted to let you all know, so we'll have questions at the end. We're recording this session, but we are not recording the question and answer period, so you can feel free to ask your questions. With that, I will welcome Dr. Levinson. Thank you very much.
I have the fancy headset. So we have a few different audio things to try to help to make sure that people can hear me clearly. So I hope that works well. And I was also told that I looked way too serious in the suit and the jacket. So we've cleverly dressed me up to look more casual and relaxed today. So I want to thank you all for having me back. I really enjoyed speaking to you before last year about dementia risk reduction. And today we'll talk about another common, important, serious, and a series of treatable conditions as we talk about both anxiety and depression. And one of the things that's important to keep in mind is the experience of anxiety disorders, depression, and major depression is very different for different individuals. So many of you may have experienced this, and you may or may not recognize some of the experiences because they do tend to be quite different. Everybody's individual experience of these illnesses depends on their background, their families, their supports in the community. I will talk a little bit about Mrs. Ellis and her experience of a specific type of anxiety that started up with her after witnessing the fall of one of her neighbors where she lived. And she became increasingly fearful about having a fall, and that impacted her life. And then Mr. Carter, John, he also is normally quite a fun-loving person, very involved in the building where he lives, loves to play chess and garden, and just gradually over time, after his children moved away, he started to become more isolated, and there was a sort of downward trajectory. So I'll use John as a bit of an example of what can happen with a major depressive episode. You heard a little bit about me already. I am a medical doctor and a psychiatrist. The particular type of psychiatry that I practice is a little different. I practice in a hospital setting, but a general hospital setting. So when people are in the hospital, usually for some other reason, they might have had to have hip surgery, or they might be in the hospital for pneumonia, and the main doctors that are looking after them consult our team to find out maybe they're worried about somebody being depressed or anxious, or they might be worried about medication side effects or things like that. So that's the sort of specialized psychiatry that I practice. Today we'll talk about anxiety and anxiety disorders. We'll talk about depression and major depression. And then we'll have lots of time for question and answer, because I'm only taking the train back at like 9 p.m. because last time we had 2 hours of Q&A, and I'm willing to tough it out again for as long as needed. So let's talk about anxiety disorders, and I want to start by talking a little bit about some of the myths around anxiety and anxiety disorders. So there's still a lot of people that believe that anxiety and depression, for that matter, are more of a sign of like a personal weakness. And that type of stigma or self-stigma, because many of us have that feeling ourselves, and it might even stop us from seeking help from a healthcare provider, getting an assessment, or sometimes being like prescribed and staying on a treatment of some kind. All anxiety is the same. Like, we throw these words around colloquially. We talk about anxiety. And I will tell you, as a psychiatrist, I see all kinds of patients who are referred for anxiety. But in our business, we actually like to be a bit more specific about, is there a specific anxiety disorder? And we'll talk a little bit about what those disorders are. We talked about that. I would say the anxiety is also one of the most common, and anxiety disorders, some of the most common mental disorders. A lot of people think that, oh, if I go to seek help and I have anxiety, some pill-pushing doctor is going to put me on a bunch of medications, so I'm not going to bother going. But it turns out that actually non-medication treatments are some of the most effective treatments for the various anxiety disorders. So we'll talk about that too. So it's good to keep in mind that not all anxiety is abnormal. I have to give a presentation in front of all of you, Dixon Hall. Little bit of anxiety helps me to do some more preparation. Having anxiety can be quite functional and normal, and is really a normal part of the human condition. To some degree, we wouldn't have survived as a species if we didn't get out of the way of the woolly mammoth in terms of the fear and anxiety response. So when is it abnormal, though? If the anxiety is excessive, if after the fearful thing leaves, or in the absence of a fearful thing, it continues and it persists to be this uncomfortable emotional behavioral feeling. And also, if the main thing that we see with all of the mental disorders or psychiatric disorders is it gets to a point where it starts to impact people's function. So it's one thing if you're anxious before a test, but you're still able to study. It's another thing if you completely avoid it, you decide not to show up, you get a sick note because you have a stomach ache. So avoidance is really the hallmark of many of the anxiety disorders. And that's kind of the point at which the function, the day-to-day ability to get by becomes an issue. So a lot of anxiety is completely normal. I think we live in a culture where people are sometimes, they're uncomfortable with difficult feelings. That's not an anxiety disorder, though. You can feel anxious and it can be normal. So signs and symptoms, it's worth thinking about. I often think there's cognitive or thinking symptoms. There are behavioral symptoms, things where you might be pacing. And then a lot of people who have anxiety have physical symptoms. They may feel like muscle tension, have problems with sleeping. So we'll talk a little bit about the fear cycle and the stress response of the body, which leads to a lot of these. We do see some very typical types of thinking patterns in people who have different anxiety disorders. So one of these is called catastrophizing. So people who have prominent anxiety often think the worst is going to happen. So it's not just that you're going to fall, it's that they're going to trip and they're going to fall and everybody's going to be looking and watching and they won't be able to get up. The other type of thinking pattern that happens frequently is something we call overestimation of probability. And that is basically, even though the odds of you passing out at the restaurant would be very slim, in the mind of somebody who has quite prominent anxiety, they think, 50% of the time I'm going to go and it's going to be a disaster. So there's this catastrophizing, and these patterns we often see if somebody's, got serious panic attacks and they recur, and then people start to avoid. They start to overestimate the probability of that happening. It's like, I can't take that flight. I can't go in that elevator. I'll pass out. I'll die. And then that cycle of other thoughts, I'm going to die. I'm going to have a heart attack. So the cognitive side, the other signs and symptoms, those are the things that we ask about when we do our detailed assessment, and those are some of the hallmarks. And you've probably heard about the fight and flight response, or the sympathetic nervous system. This is the rush of adrenaline that happens, and we know quite a lot about the fear circuit. A lot of it has to do with a hormone called adrenaline, also known as epinephrine. And once the cycle starts, the hormone goes throughout your body, your heart rate starts to beat, blood flows to your muscles in case you have to fight or run away, and a lot of the physical symptoms that accompany that sense of nervous tension, being so revved up that you can't sleep at night, feeling more irritable. A lot of people will get upset stomach because the blood's busy moving away from your stomach and going to your muscles. Your pupils might be wide. So a lot of the fear response helps to explain what happens when people have anxiety and the effects of the hormones. So if we think about what are the different types of anxiety, so not just labeling something as this is anxiety, but actually pinpointing the disorders, these are really the 5 main anxiety disorders that we are referring to. And each of them kind of depends on what is the specific feared thing. So the most common types of anxiety disorders are actually what we call specific phobias. And they're not all that functionally disabling, even though they impact people's function. But if you have a fear of flying, unless you're a jet-setting executive, it might not be that big a deal. But if you do need to fly for your work, that specific phobia could actually be quite impactful. But things like fear of snakes, spiders, dogs, fear of snakes is quite common and not usually all that disruptive in Canada. But if you have to move to Australia, that could be another story. And I think it's reasonable to be a bit afraid of snakes in Australia myself, but a phobia is getting to the point where it's like, okay, I don't feel comfortable going out. We will see people sometimes in the hospital who have a blood injection or like a medical phobia of having procedures, and that can really impact the ability to like attend clinic appointments. So a lot of people avoid going to the doctor if they feel like, oh, they're going to order blood work, and I don't feel comfortable doing that. I've treated some medical students for that because before they would go to their rotations and they couldn't really participate fully because they felt so uncomfortable and fearful about blood. So specific phobias are one type. Social anxiety disorder, which is also known as social phobia, is usually associated with the embarrassment, fear of being judged by other people. And of course, like some people will experience some of that, but at its more severe form, it can be quite devastating. So what we often see for people who have very severe social phobia or social anxiety disorder is their life path kind of changes around the age of 15 or so, where they start to skip out on presentations at school. Maybe the courses that they choose in university, they pick ones where they won't have to do any presentations or interact with people. They may refuse to take jobs, and it could affect their career because they don't want to be put in social situations where they fear embarrassment or humiliation. So at the more severe end of the spectrum, can people become quite socially isolated. Generalized anxiety disorder, just like it sounds, is kind of anxiety about lots of different things. So there might be, just these are the people when you ask them, would you describe yourself as a worrier? And they're like, oh, yeah. And their family do too. Oh, they worry about everything. When I talk to mom, she's worried about the news on TV. She's worried about, the safety of the grandchildren. She's worried about finances. And, obviously some of those things may be very, very legitimate things. But in GAD or generalized anxiety, it's like disproportionate. The person can no longer control the worry and is excessive, and other people in their circle find it to be excessive. These people also will have a lot of physical symptoms, muscle tension, problems with sleep. Usually they're restless and pacing a lot as well. So that's GAD or generalized anxiety disorder. Panic disorder, so panic attacks are quite common. Up to about 30% of people at some point in their life may have a panic attack. A one-off panic attack doesn't mean you have panic disorder, but if it recurs and you start to worry about having future panic attacks, and it leads to problems with your day-to-day function, usually avoidance, then we say you might have panic disorder. And a panic attack, probably some of you have experienced it. It's usually a relatively intense surge of anxiety throughout the body that also affects the thinking. Typically lasts about 15 to 30 minutes, kind of this crescendo, decrescendo wave of the adrenaline. People get very fearful. They have all those symptoms. They may start to sweat or shake. They often get like a lump in their throat. They may feel like they're going to pass out or go crazy or die. And then it usually subsides over time. Sometimes people have agoraphobia along with it, which is sort of often associated with a fear of not being able to escape someplace. So there's like classic situations where people will have panic attacks, like going to a large concert or a stadium, having to drive across a bridge, fears where you don't think you can escape from the situation. So these are the main categories of anxiety disorders, and when we assess somebody, we're looking to make a specific diagnosis of a defined anxiety disorder. So if we think about Mrs. Ellis, as I said, she's living in a retirement home, and she has never had any issues with anxiety or depression in the past, but she sees her neighbor fall. She's kind of traumatized by it. She starts to ruminate about it. And gradually, she can't seem to stop thinking about it, and she starts to worry about her own risk of falling. And pretty soon she starts to stop going out. Even within her home, she's like worried about falling every time she walks around. She stops going to activities in the home. She's worried about losing her independence. She's worried about becoming a burden to her family, even though she herself hasn't fallen. The anxiety about it, this kind of specific fear of falling, has become so intense that it's now interfering with her day-to-day life. So fear of falling is actually one of the specific phobias that is quite common amongst many older adults. So what causes anxiety disorders? And this is where when I was chatting with people beforehand, the medical science is still quite in the dark on really definitive causes of many of our mental disorders. We often talk about different mental disorders as being diagnoses of exclusion. In other words, we've ruled out other things and we're left with this constellation of signs and symptoms. And so we conceptualize the causes of anxiety as probably a mix of different things. There might be biological and psychological and social aspects, and we do know that there's certain people who are kind of predisposed to it. We know there are runs in families often. We think that people who have these like highly reactive temperaments as babies are at higher risk for developing anxiety disorders. Doesn't mean they will, but they are at slightly higher risk. And so it's a little unsatisfying. We don't have a test to say, oh, you have it and here's the cause, but we basically have a list of signs and symptoms and we try and rule out other things that might have caused it. But as to the underlying things, there's more and more research being done, but no real definitive. So it's probably a mix of all of these for many people. And even thinking about the cause effect in terms of learned behavior versus genetic. Let's say my mom is terrified of dogs and I watch her being fearful of dogs and running away from dogs. Is that a learned behavior because I watched her run away from dogs for all of my early life, or was that genetic? It's sort of hard to pinpoint, or a bit of both. So hard to know. So what do we do when somebody comes to see us with anxiety symptoms? And I should say, often people don't come to see us very quickly. So anxiety disorders, while many of them appear in childhood or in adolescence, it's one of the things where people often delay going to seek help, whether from stigma or they're not sure there's an issue or they don't think anything can be done about it. But the time delay sometimes for people to seek help for anxiety symptoms and anxiety disorders can be quite long. And often what happens is they don't come because of the anxiety. The anxiety's gotten so severe and the function has gotten worse, and they often have developed a depression secondarily. So I would say a lot of the patients that come and are seen with anxiety disorders, the reason they're actually seeing the doctor is because of depression. And so it's really important for us as clinicians, when we're doing the assessment for depression, not to miss whether or not the person actually has an underlying and important anxiety disorder. So doing a comprehensive assessment is really important. When you go to see a healthcare provider, they should take a detailed history to try to understand how long the symptoms have been there, whether there's a family history, whether it's associated with anything medical, a medical illness, medications that can trigger it. I'm often just overwhelmed by the number of people that drink enormous quantities of coffee and don't think it's going to make a difference. So sometimes I remember seeing somebody who had very bad panic and anxiety, generalized anxiety, and I asked them how much coffee they drank, and they were like, 2. And I was like, oh, okay, 2 cups of coffee. No, 2 pots, 2 pots of coffee. It's like, okay, now we're talking. So, a lot of people ingest these very caffeinated beverages, and they that's an important intervention that could be done for people with anxiety. So taking a detailed history, a lot of the other things that we're doing are looking to rule out those other causes. So we're doing a physical exam to see, can we see any signs or symptoms of something like a thyroid issue? Because people who have hyperthyroidism, that can stimulate metabolism in the same way as 2 pots of coffee and cause a lot of anxiety symptoms. There are standardized questionnaires that are sometimes used. Normally, those are screening questionnaires. So if you were to see your primary care provider, they might give you a short questionnaire called the GAD-7 or the GAD-7. And again, that's a screener where you would then expect somebody to follow up if they answer some of the questions that suggest that they're having prominent anxiety symptoms. If you go to a specialty clinic, sometimes you can expect to see even more forms or have these like longer assessments with sort of standardized interviews where they'll run through all the symptoms of panic disorder and all the symptoms of generalized anxiety disorder. But normally in primary care, this is what you could expect is a detailed history, a physical exam looking for medical causes, possibly a screener that you could even fill out before the appointment. And then, if appropriate, or concerns around a specific medical illness that might be causing the anxiety symptoms, there might be some specific tests that are ordered. The diagnosis, as I said, it's really more about ruling out other causes and then diagnosing the specific disorder. So that's why I do find it a little frustrating. I don't want to be too whiny as a psychiatrist, but I find it interesting that there are a lot of people that are just given a label of anxiety, not a specific diagnosis, and sometimes they're even started on a treatment, like a medication treatment, without a specific diagnosis, which I find to be a little unsatisfying. So if that happens, I like to go back to the person and say, okay, let's see if we can work through this and figure out what the specific diagnosis is. The other thing that's important to keep in mind, I talked about the risk of people with anxiety having depression. It's probably about 80% of people with an anxiety disorder will at some point in their life have a major depression. But they come in clusters. There are a lot of people who have more than one anxiety disorder. So that's another piece that's sometimes challenging in psychiatry, is it's not always just one diagnosis. It may be more than one. So somebody may have panic disorder, but they may also have generalized anxiety disorder, and you want to get it right because you might need to treat more than one condition. So treatments here, that is very much the good news. There are excellent treatments for every anxiety disorder. Really the first line treatments for almost every anxiety disorder are non-medication treatments. I'm going to talk a little bit about the most common framework for non-medication treatments, which is cognitive behavioral therapy. But really, what we usually start with is education. There are self-help resources, a lot of self-help books out there. Many of them are based on the principles of cognitive behavioral therapy, which is quite effective. And then there are also medication treatments as well. For most of the anxiety disorders, the first-line medication treatments, confusingly enough, are antidepressants. So the category of antidepressant medicines, and there is a move afoot to try to rename our drugs so it's less confusing. Why are you using an antidepressant to treat anxiety? But the same medicines, SSRI medicines or SNRIs, and I will talk a little bit more about the medicines and their side effects when we talk about depression. But those medications are also helpful, and some patients may require a combination. I think there's a lot of people, maybe in the old days that were given sedative type anti-anxiety medicines, the class of medicines we refer to as benzodiazepines. These are the ones that end in apam, lorazepam, clonazepam, temazepam. Generally now with older adults, we think there are more side effects than benefits from that class of medication. If people have been on them for many, many years, you have to be quite cautious about very slowly tapering people off of it. Or you might look at it and say, actually, the person's doing well on it, so maybe we won't touch it. But there are risks of side effects like cognitive side effects, memory impairment, balance issues. So lots of potential side effects. So in the normal way now, if an older adult is diagnosed with an anxiety disorder in late life, they will not usually get started on a benzodiazepine medicine. In the normal way, the first line would be cognitive behavioral therapy, and if there's no benefit from a good course of cognitive behavioral therapy, maybe a trial of an SSRI type of medication. So, cognitive behavioral therapy is a framework. So we usually have a specific version of CBT depending on the specific anxiety disorder. So there's kind of like a panic-specific version of CBT or a generalized anxiety disorder specific version. Specific phobias often involve more of the behavioral type treatments, including things like pop-up books with spiders on them. Sometimes you have to start small and build people up. And so there's usually an approach where you give people some skills, some education, and you help them to face their fears with some of the tools in mind. Breathing techniques that can help with that fight or flight syndrome. Cognitive techniques, ways of thinking that reduce some of the fear and giving people the tools such that they can actually face the fear rather than avoid it. So that's and it's been studied in all the anxiety disorders and is very effective. It's quite flexible in terms of format, seems to work with different age groups, seems to work if it's delivered over the internet or in person in a group with individuals. So it's one of the most commonly taught psychotherapies now because it's relatively brief, sort of 3 months, 12 to 20 weeks. And so the province of Ontario, which recently started to fund structured psychotherapy through certain sites that specialize in it. It's based on the British model. But this is a really important change to our government policy around it, because before that, you either had to have private insurance or be able to pay out of pocket, or maybe you had employee assistance, but it was not always that easy to access CBT, and it is easier to access CBT now. I'm not going to lie, it's still work. You still are facing your fear, and there are still people who actually opt to go and try a medicine because they don't necessarily want to engage with a course of CBT, but it is still probably the most effective first-line treatment for most of the anxiety disorders. Medications I spoke to you about, the most commonly prescribed ones are medicines in the SSRI family. So those are ones like Prozac, Zoloft, so sertraline or Zoloft. We have two names, right, for every medicine, just in case the patient learns it. We want to mix it up so we can talk code. But yeah, so fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil. Those are the SSRIs that are most commonly prescribed. The SNRIs, these are serotonin norepinephrine reuptake inhibitors. So those ones are ones like venlafaxine or Effexor or duloxetine or Cymbalta. And as I said, somewhat confusingly, these are often talked about as being antidepressants, but they are also the most commonly prescribed medicines for the different anxiety disorders. There's a new kid in town on some of the guidelines, a drug called pregabalin or Lyrica, which some of you may be familiar with. It's used sometimes for fibromyalgia or nerve pain in diabetes. It's classed as a gabapentinoid. It is sometimes used now in the setting of generalized anxiety disorder, but not that commonly. General principles, especially with older adults, are start low, go slow. SSRI medicines used to treat anxiety have the side effect of anxiety and restlessness if they're started too quickly or at too high a dose. And we will see this quite commonly. Patients with anxiety are very sensitive to bodily symptoms. It's part of what happens in like the panic cycle. They feel something. So they're almost like hyper attuned to their body's sensations. So they're very sensitive to side effects as well. So if you start one of these SSRI medicines at like the normal starting dose, a lot of people with anxiety can't tolerate it. They get restless, they feel very uncomfortable, they stop the medicine. And I will say lots of patients that we see with anxiety disorders, they say, oh, I can't take, the Prozac. I can't take Zoloft. I tried it. I tried this. I tried that. They've tried everything, but they haven't necessarily had a trial where somebody started the medicine at a low enough dose, got them used to it, and then very gradually increased it. Sometimes we have to use like a liquid version with an eyedropper to get people who are really sensitive, but it can be done, but you have to be careful about it. And then you're usually looking at it as a longer term approach, and sometimes in conjunction with cognitive behavioral therapy. Really important not to stop those medicines abruptly. There are withdrawal, emergent, or discontinuation effects. I think not enough people, prescribers, when they start a medicine, they don't often talk about not stopping it abruptly. So people can have quite bad side effects if they stop one of those medicines abruptly, similar to the benzodiazepines, where you can have quite bad withdrawal. Okay, so we are coming to the end of anxiety. Common, excessive, and fearful anxiety that persists, is excessive, and impairs the person function. Lots of importance to getting a thorough assessment to rule out potential medical causes or other causes and get the diagnosis accurate, and very effective treatments, especially non-pharmacologic, non-medical treatments. So, now that we have talked about anxiety, let us talk about major depressive disorder or depression. That resource, so in the handout, there is a lot of the summary of the key points, but there's also a link to, on the McMaster Optimal Aging portal, we have about a 30-minute, 35-minute e-learning lesson on anxiety and anxiety disorders, a lot of the stuff that I've talked to you about today. But if you have friends or family that couldn't attend, or somebody you want to learn about it, you can share the UnderstandingAnxiety.ca link. It is freely available on the portal. There's also, I'll talk to you about, there's a way you can get an email series on the same topic if you prefer email. So let's talk about depression. Myths. And again, I will restate the myths around stigma, self-stigma. People feel like, oh, this isn't a medical disorder, this is a sign of personal weakness. But depression's a part of natural aging. That's a myth, especially a lot of older adults. It's like, well, I'm not what I used to be. Of course I should feel this way. I have aches and pain. Depression, it's rare. Nobody has depression. Turns out it's actually quite common, especially in older adults, and especially older adults in certain settings, like long-term care homes and in hospital, many of the people in the hospital that we see. Depression will go away on its own. Well, for some people it does, but for others it may well persist and become chronic. So, kind of like the normal anxiety versus an anxiety disorder, we throw around the word depression in the colloquial way. I'm not criticizing that, but we do distinguish between somebody, who's had a bad day and says, I feel depressed, versus clinical depression or what we call major depression. And major depression is persistent. It has to last at least 2 weeks. And it's like you feel you have a certain range of symptoms, and depressed mood is one of them. I'll show you the symptoms in a second. But it's like every day for most of the day for 2 weeks, along with this whole range of other symptoms. So there's a big difference between I've had a bad day, I feel depressed, or I feel sad, and a major depressive episode and major depressive disorder. So I want to make that clear. But I think in common parlance now, it is very common for people to say, "Oh, I'm so depressed. I feel depressed." So when we talk about the criteria, again, similar to how we make most of our diagnoses in psychiatry, there is basically a checklist of symptoms or criteria. We don't have a test that we can do. What we do is we ask people, which is part of the reason why they get given standardized questionnaires sometimes. But as I was saying, you need depressed mood or a lack of interest or pleasure in things for at least 2 weeks, and it's most of the time, most days, and it has to interfere with your function as well. The other symptoms that go along with it, disturbed sleep. For some people, that is problems sleeping, but it can also be too much sleep. People who are can't get out of bed, they're in bed sleeping. Too much or less appetite. More commonly in older adults, I would say it is a reduction in appetite, but there are some people that will actually eat more. Poor concentration, not able to follow programs or read and not able to enjoy it, low energy, feelings of guilt or worthlessness. Another one that's in the poor concentration, sometimes we'll see people are very indecisive. Maybe in their normal way, they don't have problems making decisions, but when they have a major depressive episode, all of a sudden they're really struggling to make decisions. This can, usually we see changes in activity, and again, it might be that somebody becomes kind of restless and pacing, they're sort of hyperactive, but other people are slowed down and lethargic, and they're almost like if you in the interview, they might not even be moving much or speaking much. And then at its more extreme, people may begin to have thoughts of self-harm or ideas of wanting to die or even thoughts about taking their own life. So when we think about Mr. Carter, who never had issues previously and was doing well, kind of the life of the party in his retirement home, enjoyed gardening, enjoyed chess. He was very active with his children and his grandchildren, but his daughter moves out west to be with a new partner. He's all of a sudden, and it's like coming up on winter, all of a sudden he finds that he's losing his appetite. He's lost a bit of his spark. He used to get together with his grandchild frequently, stops going to chess, and there's kind of a vicious cycle. The daughter comes back 3 months later and notices that he's like quite thin, not eating. He's basically in his room, not participating. So he's had this kind of downward trajectory that is sometimes seen in a major depressive episode, and kind of it may start with subtle changes in lack of interest, and then the changes in sleep, appetite, low energy will sometimes like spin out of control in that way. And some of the things that are often protective are being engaged with the community, being socially active, being physically active. And so as the depression kind of sets in, often it's a bit of a vicious cycle as people become much less social or active, which can worsen their sense of connection. Again, I have no really solid answers to tell you about what causes depression. And again, it's this sense that for some people, even with risk factors, which we'll talk about in a second, for some people, there's just no obvious cause. So there, a lot of theories about what might cause depression. Again, this sort of vague biopsychosocial, maybe it's some genetic aspects, and we do know that family members and twins are more frequently at risk, but that doesn't mean that if you have a twin, you're 100% going to get it. It means it's like maybe 50-50. So there's genetic factors and biological factors, but they're not deterministic for people. So a range of different factors. If you've had adverse childhood experiences, again, your risk is increased, but many people who have had adverse experiences actually become very resilient, and that may be protective. So again, a lot of differences between different individuals. There are medical conditions that can mimic the symptoms of depression, and I would say one of the very common things that we see is substance use disorders and substance use, like alcohol use disorder, that can look just like depression. So again, when people come to do an assessment, really important to rule out a medical cause, substance-related cause, and other factors that might have triggered it. I think there are a number of risk factors that are sometimes a bit more specific for older adults, though it will depend on individual circumstances. But, having to potentially move, retirement. For many people, there's a lot of gloss put on the notion of retirement, like, oh, life's going to be great when you don't have to go to work. But for many people, it gives them a sense of purpose for many, many years. And so they often struggle with my sense of purpose after I've retired. You may have friends as you age, more friends pass away. I know many people, including in my family, who are inveterate obituary readers, and so it's a challenge sometimes to kind of maintain a positive outlook. And when you do have friends or family members, or especially a spouse, or even in some cases children who are dying, becoming socially isolated is a risk. Not everybody who's socially isolated is lonely, but there are increased risks of loneliness when people are socially isolated, and it is a risk for depression. People who may have certain chronic neurological, like brain diseases, or medical diseases that lead to things like chronic pain or affect your mobility, which can impact your independence. So there are some, legitimate risk factors for many older adults that may put them at slightly higher risk of depression as well. The principles around assessment of depression are quite similar to what I spoke about with the anxiety disorders. You're doing that detailed assessment, taking the detailed history. If somebody's had a history of depression previously, that they are at higher risk for a recurrence as well. So getting a history of that may also be very helpful in terms of, well, what was it? What was treated? What were you treated with, and did it work out well, or did you have side effects? So, but just trying to understand, could there be another medical illness there? But there is no test, a blood test, a brain scan, an EEG scan. That's where you look at brain. There's no specific test that says, aha, we've diagnosed it, you have a major depression, which is, I think, for some people is kind of frustrating. But the best we can do is say, well, we've looked to make sure it's not a brain tumor. You don't have a thyroid disorder. It's not this, that, or the other thing. So then we can say we would label this as a major depression. I think this is an important and, again, kind of confusing aspect. Just like people can have more than one anxiety disorder, you can have depressive symptoms that might not be major depressive disorder. Could be other things. And again, as part of a more comprehensive psychiatric assessment, we are trying to figure out, could it be one of these other things, or is it depression, or is it one of these other things and depression. So again, adjustment disorder is a term when there's been like a major life stressor. So many of the patients that I see in the hospital, maybe they've just been given a cancer diagnosis, or they've had a surprise fall and hip fracture, and they're still like adjusting to it. They don't necessarily have a major depression. When their family comes to visit, they brighten up, but they're dealing with a lot, and they're having what might say like more than normal depressive symptoms, but not enough to be labeled as a major depression. And part of what we think of conceptually is if the stressor goes away or the person has enough time to use their normal coping, then their depressive symptoms will also go away. So that's another important one. Persistent depressive disorder is similar to a term you might have heard before called dysthymia, and it's more of a like chronic depression. It doesn't have all of the same number of symptoms or same severity of symptoms as a major depression, but it can also still really impact people's lives because they tend to have more chronic low mood and some symptoms. Bipolar disorder, which used to be known as manic depression. So especially if a young person presents with an episode of depression, you really want to be careful that the diagnosis is major depression and not, is this depression part of a bipolar disorder? Because the person may have had other episodes where it was either the opposite of depression. So we're usually screening people to try and make sure that we haven't missed somebody who has bipolar, because actually the treatments can be different. Grief, obviously, if somebody dies, but if it gets complicated or is prolonged, that can look a lot like depression. And then I mentioned before some of the medical issues. Sometimes when people are having cognitive symptoms in the hospital setting, I see a lot of people with delirium or acute confusion. Maybe they've been given, drugs from an operation or something like that. But delirium, a lot of people don't know, can also present with low mood and can look like depression or anxiety. So really important to make sure that, there's not an infection or some other kind of side effect going on. The approach, many different treatment types. At the milder end of a major depression, we might focus on education and self-help approaches. There's more and more evidence accruing around the role of physical activity and exercise, both as a treatment as well as a prevention strategy. Non-pharmacologic approaches, and again, there's a version of that cognitive behavioral therapy, or CBT, for depression. Very effective, flexible, different formats. There's other types of psychotherapy that are also used, and I think in the Ontario's structured psychotherapy, they offer CBT, but they also offer another one called interpersonal psychotherapy that can be very effective if people are going through grief or a role transition. So there are different types of psychotherapy. I'm focusing mostly on the CBT. Antidepressant medicines, which we'll talk a little bit about and we spoke about before. And then typically reserved for more severe cases or people who have not responded to psychotherapy or medications are a range of different brain stimulation treatments. So RTMS, or transcranial magnetic stimulation, and electroconvulsive therapy, or ECT, used to be known as shock therapy. So that is still used today for people who do not respond to depression, but it's done in more safe and controlled ways than when it was used when it was first introduced. So antidepressant medicines, and again, those ones I was talking about before, the SSRI ones or the SNRI ones are typically the first line. There's about 9 or 10 first-line medicines. Most are in those families. There's another one called Wellbutrin or bupropion as well. They usually don't work right away. They might take 4 to 8 weeks. You got to make sure somebody can tolerate it, get them on the right dose. So again, that approach where you might start low, go slow, make sure somebody's at least able to tolerate the medicine. A lot of the side effects, which we'll look at in a minute, do go away after the first week or two, but especially if the dose is a bit high, the side effects may persist. It's a little bit of trial and error. So as much as, we might hope that somebody responds to the first medicine, we again don't have a good test or way to predict which person is going to benefit from which medication. So there's often more than one medication trial involved, and that can be very frustrating for people. Like, you're continuing to experience the symptoms, you're trying one medicine, you're trying it for 4 to 8 weeks, and all of a sudden it's like, this isn't really working, we're going to have to switch you to another one. Sometimes people will add another medicine to the antidepressant. Let's say there's been a partial response. Often you'll see people say, okay, there's been some gains, you're not fully better, let's add another adjunctive medicine and hope that we can improve the response. We usually think of the acute treatment period, and let's say that might be, we want all of your symptoms better, so that might be, say, the first 3 months of treatment, and then after, we want to maintain that response. So one of the worst things you can do is somebody's getting better and then they stop their medicine. That increases the risk of relapse pretty significantly. So we usually treat for at least 6 to 9 months after the full remission of that episode of depression. And so I often will tell people, if we're starting a medicine, we're in it for the long haul. You're looking at least a year typically, where you have your acute phase and then your maintenance phase. And for some people who may have had a longer depression, we might recommend a longer period of treatment. And for some people who have had 3 or 4 episodes where their risk of a recurrence is very, very high, we might recommend that they stay on a medicine maintenance for life. Obviously, depending on how well somebody's tolerating it and their own sense of, it's very disruptive to a person's life to have a depressive episode. So for some people, staying on that medicine and reducing the risk of a relapse can be very important. Yeah, 10 minutes. And then what? I think Dan's going to turn off the mic in 10 minutes. Side effects are quite common with different antidepressants, unfortunately, and I would say especially when medicines are, say, started at too high a dose, when people increase the dose too fast, or on the converse side, when people stop a medicine abruptly and haven't been advised that, you might have withdrawal effects if you stop this. So the common ones that we usually see: headache, nausea, diarrhea, GI symptoms, those ones often go away after a week or two, and not everybody even has them. But sexual dysfunction is a common one and usually more chronic. Irritability or restlessness, as I was saying, with especially if people have anxiety as well, even though they're good treatments for anxiety, often people will feel a bit revved up when they first start on the medicine until their body gets used to it. Weight gain is common with most of the antidepressants, not all of them, but most. And then I talked to you about the withdrawal emergent. There are some other more serious ones, especially in older adults. They're at risk of an effect on their sodium level that can be quite serious. So normally when we do start a medicine in an older adult, we will check the sodium before we start, and usually at least by 6 weeks. And same on, some people are more sensitive. Their heart's conduction system can also, so we usually will get an ECG or EKG before starting an older adult, and we might check it again later. So with John, he started on a combination treatment because his depression had gotten a little bit spun out of control. He was losing weight. His daughter was quite shocked when she came back to visit at the 3-month mark. So she did go with John to see the physician, their family physician, had a comprehensive assessment. There was no medical cause found. He was simultaneously started on a medicine and referred to a group for cognitive behavioral therapy. And over the course of the first few weeks, he didn't really notice his mood changing, but his appetite improved a bit and his sleep got a bit better. By the 4th week, he was actually starting to participate again in some of the activities in the home. And then he noticed at about the 8-week mark that actually his mood was brighter and he was quite a bit more himself. Prevention, I mentioned physical activity, and trying to tackle social isolation is another important thing. So Canadian guidelines on seniors' mental health have really tried to emphasize more activity, reducing social isolation, coming out to Snacks and Science as often as possible. In Britain, they have a minister for loneliness. Actually, there's been some talk about really trying to get a handle on the effects of social isolation and loneliness. So, quick summary then, because Nadia said, a persistent 2 weeks sadness most of the time, most days, over at least 2 weeks with that range of other symptoms. You should get an assessment because it's important to rule out other medical causes that might be causing the depressive symptoms. There are a range of treatment strategies from self-help to non-pharmacologic or psychotherapies to medication. Physical activity, reducing social isolation, those things have been shown to help prevent depression as well. And then when it comes to medication or treatments, lots of options out there, including structured psychotherapies like CBT, medicines for some, or a combination may be necessary for others, and really important to have follow-up and maintenance treatments to try to reduce the risk of relapse. Like with our anxiety program, on the McMaster Optimal Aging portal, there's a e-learning lesson about understanding depression, so UnderstandingDepression.ca. And there's also an email series that basically covers a lot of the same things that I spoke about today. But again, if somebody wasn't here today, I know you're all fans of the portal, or some of you are. Some have said that you want nothing to do with the internet, and I appreciate that. I don't either, and it's my area of research. But the portal is your source for all types of evidence-based health information and social information you can use, including some of the content that I've talked about today that is available through various e-learning lessons. So again, if you had a loved one that you wanted to share this information with, on our e-learning page, you can access depression, anxiety disorders. For some of you who somehow managed to miss my appearance last year when I was talking about dementia and dementia risk reduction, there's a whole series on the portal on understanding dementia, on how to promote brain health as well. And you can also subscribe to what we call micro-learning, where you get one email a week on a different topic, depending on the topic that you choose. And those are all free and available. And I have hit my 10 minutes on the nose. So, yeah, thank you.